International Diabetes Federation. We'll try our best here to give a brief about these guidelines. So without further delay, I have to welcome the first speaker, Dr. Nida Bukhari. Dr. Nida, she is a consultant diabetologist in a Noor Diabetes Center. She will talk about epidemiology of diabetes and fasting Ramadan. So welcome, Dr. Nida.
This is Dr. Nida Bukhari, and first of all, I would like to thank you all for giving me this opportunity to be with you today talking about the epidemiology of diabetes and Ramadan fasting. Let's start with this الآية الكريمة. أعوذ بالله من الشيطان الرجيم. شهر رمضان الذي أنزل فيه القرآن هدى للناس وبينات من الهدى والفرقان فمن شهد منكم الشهر فليصمه من كان مريضا أو على سفر فعدة من أيام أخر يريد الله بكم اليسر ولا يريد بكم العسر ولتكملوا العدة وتكبروا الله على ما هداكم ولعلكم تشكرون. As we see from this ayah al-Karima from Surah Al-Baqarah that Allah gives some exemptions to certain of people not to fast in Ramadan, such as elderly, children, pregnant women, people with chronic disease like diabetes, chronic kidney disease, and ischemic heart disease. And although Allah gives them exemption and excuse not to fast, but they prefer to fast for so many reasons. One of the reasons is time of the year with varying of daylight duration and weather changing. As we know, Ramadan is coming in Hijri calendar, and we have the weather of the year are coming in the geographic calendar. So Ramadan will varies from year to year. Some Ramadan we will fast in winter, and some of Ramadan we will fast in summer, and etc. Other causes are fasting alone without the family outside of Ramadan would be challenging because some patients don't want to miss the great vibes of Ramadan with others. And some patients think that ajr or thawab of fasting wouldn't be the same if they miss fasting in Ramadan. So do we need for practical guideline or on diabetes management during fasting in Ramadan? The management of people with diabetes who fast during Ramadan has generally been based on expert opinion rather than medical evidence gained from scientific data. But however, the introduction of the first edition of IDF-DAR diabetes and Ramadan practical guideline 2016 provided a practical tool to help healthcare providers support their approach to safely guide people with diabetes who wish to fast the holy month of Ramadan. Another question is, why is this guideline important? Muslim living as a minority in any country, include the Americas, Oceania, Europe, may need extra attention since healthcare professionals who are not experienced in dealing with fasting people with diabetes might not consult or even be aware of published recommendation. This is one of the reasons. Other reasons are different countries have varied fasting practices during Ramadan. Research conducted in the Middle East and North Africa region and globally have shown that many people with diabetes still do not receive Ramadan-specific education. People with type 1 and some of the type 2 diabetes are treated with basal bolus insulin, and there is evidence to suggest age-specific differences among those with type 1 diabetes in fasting practices and outcomes during Ramadan. Most countries with majority Muslim population are in less developed region of the world, and less developed countries are disproportionately affected by diabetes. And finally, furthermore, data reported in 2019 showed more than 79% of people with diabetes were living in low and middle income countries. Ramadan and diabetes have potential risk and also have potential benefits. So the most or major risk that the patient with diabetes will face in Ramadan are hypoglycemia, hyperglycemia, dehydration and thrombosis, and acute metabolic complications such as DKA, But on the other hand, fasting in Ramadan has so many benefits, such as better lifestyle, assessing weight loss, smoking cessation, and for patients with diabetes who choose to fast Ramadan, may help strengthen the therapeutic alliance between the patients and physician and can provide opportunity to improve diabetes management with a focus on self-care and the regulation of medication and meal timing. So over recent decades, the prevalence of diabetes has been increasing throughout the world, and this trend is set to continue. And talking about the diabetes globally by number, we can say that estimates for 2019 indicated that there were approximately over 400 million people with diabetes in the world, with a 1 in 2 adults are unfortunately undiagnosed, with over 200 million people, and those total number is predicted to rise to the 700 million, which is about 10.9% by 2045, with a 51% increase. There are two important aspects to consider about the epidemiology and diabetes. First of all, the number of people with diabetes in International Diabetes Federation in Africa region is projected to have the highest increase of all IDF region by 143% by 2045. The second reason is the IDF Middle East and North Africa region currently has the highest age-adjusted diabetes prevalence of all IDF region by almost 12%. As we can see here, this is the map of the world, and we will move from the highest to the lowest proportion of the world Muslim population. As we can see here in Asia Pacific, they have about a 900 million proportion of Muslim the Muslim population. This is the majority. And then Middle East, North Africa with over 300 million. And then the third place, we have Sub-Saharan Africa with over 200 million, Europe with 43 million, North America with a minority of over 3 million, and the least country, which is the Latin America, Caribbean, with 800,000. The approximate percentage of the total population that are Muslim in different geographic region are as follow: 93% of the Middle East and North African are Muslims, whereas 38 of the Central Asia, 42 of the Southeast Asia, 31 of South Asia, from 29 to 31 of Sub-Saharan Africa, 5% only from Europe, and 1.5 for Oceania, and 1% only from the Americans are Muslim, and all of these region impact with diabetes. The approximate percentage of the number of Muslims is projected to increase by 73% by 2050, which will make Islam the fastest growing world religion over the next 4 decades. The prevalence of diabetes may vary within region or even between communities within the same countries. For example, we'll have a study from the United Kingdom that the age standardized prevalence of type 2 diabetes in the South Asian was almost 4 times higher than the non-South Asian. Here, I'm talking about the 64% of South Asian came from majority Muslims, such as Pakistan and Bangladesh, who live in the United Kingdom. And similarly, patients with diabetes who belong to ethnic minority group in the United Kingdom and North America have been found to be a greater risk to developing diabetes-related complication. So why is the prevalence of diabetes is increasing among all the population around the world? We have so many reasons. First of all, rapid modernization for future generation will see increase in life expectancy and increase urbanization and reduction in the burden infection disease. Dramatic changes will have a negative impact on lifestyle, and that will include increase in level of poor quality nutrition and sedentary behavior that in turn facilitate weight gain and increase in risk of diabetes. And smoking also one of the cause of the increasing the prevalence of diabetes. Now we talk about the epidemiology of diabetes. We divided the epidemiology of diabetes into two categories: the epidemiology of type 1 diabetes and epidemiology of type 2 diabetes. Regarding the epidemiology of type 1 diabetes, we have three major studies, which are EPIDIAR, DARMINA type 1 diabetes, and DAR Global Survey. For EPIDIAR, the information was collected from over 12,000 Muslim people living with diabetes across 13 countries, and the study found that 42% of patients with type 1 diabetes and 78% of those with type 2 diabetes reported fasting for at least 15 days during Ramadan, and only 67% of patients with type 1 diabetes and 37% of patients with type 2 diabetes were self-monitoring their blood glucose level. And approximately half of all EPIDIAR study population didn't change their lifestyle during Ramadan. And recommendations were from treating physician were provided to 68% of patients with type 1 diabetes and about 62% of patients with type 2 diabetes, and the majority of patients didn't change their medication dose. And the number of severe hypoglycemia episodes per patient per month was unfortunately significantly higher during Ramadan than during the preceding year for all patients. What about the DAR Global Survey Type 1 Diabetes? It was conducted about 13 Muslims populated countries, and surveyed during post-Ramadan visit were including intention and ability to fast, impact of COVID-19, rate of hypoglycemia and hyperglycemia, and self-monitoring of blood glucose, and type of education received. And total of 1,400 over type 1 diabetes participated. Here's a comparison for DAR Global Survey between the type 1 diabetes who are over 18-year-old and under 18-year-old. We can see here over 61% of the patients younger than 18-year-old was having 61 of hypoglycemia and hyperglycemia. On the other hand, only 45% were having hypo and hyperglycemia for the more than 18-year-old. SMBG were almost similar with 97 and 95 respectively. In shorter duration of diabetes and fewer comorbidities and diabetes-related complications were with younger than 18-year-old. On the other hand, longer duration of diabetes, more comorbidities and diabetes-related complications were with the more than 18-year-old, and higher level of hemoglobin A1C by 9, which was 9.5 for younger than 18, and 8.5 were with older than 18-year-old. Here's a column chart that compare between the age of less than 18-year-old and more than 18-year-old. As we can see here, fasting between 8 days and 4 days were about 12%. On the other hand, who completed the whole month of fasting were only 0.6, and the most common time of getting hypoglycemia were between 3 p.m. and the time of Maghrib, which was about 40% of all hypoglycemia. DAR Global interest in intention to fast according to differences geographically, with the lowest rate of fasting were in Turkey by 13%, Morocco by 22%, Algeria by 26%, and that's according to the DAR Global Survey. And highest rates of fasting were with Pakistan by 76% and Malaysia by 85%, and the majority of fasting was in Kingdom of Saudi Arabia by 90% of the population of type 1 diabetes were fasting in Ramadan. Darmina, we're talking about the pattern of diabetes care among people with type 1 diabetes. It was a prospective study with cohort. And here's a comparison between the three of the studies that are talking about the diabetes in Ramadan among type 1 diabetes, EPIDIAR, DARMINA, and DAR Global Survey. We can see that intention of the fast with highest with DARMINA and fasting over 15 days with DAR Global. And The majority of the fasting of completing the 3 days were with Darmina. The proportion of participants with type 1 diabetes were 8% in EPIDR, 7% in Darmina, and 20% of type 1 diabetes in DAR Global Survey. Here's the continuation of the table. As we can see, here is a comparison between the complication, micro and macro complication, hypertension, dyslipidemia, and etc. What about the epidemiology of type 2 diabetes? In addition to the last study, to the 3 last study, we have a special study who are for the epidemiology of type 2 diabetes, which is CREATE study. CREATE study, a multi-country retrospective observational study. Data were reported to for a total of over 3,000 patients with type 2 diabetes. 94 reported fasting for at least 15 days during Ramadan, and 63 of the patients fasted every day during Ramadan. And nearly 30% of the Muslims with diabetic who fast during Ramadan also fast at other times of the year. As we can see here in pie chart, 94% of type 2 diabetes who fasted more than 15 days during Ramadan, 32 of them fasted less than every day, and 67% of them fasted about every day of Ramadan. Guideline or recommendation for the management of diabetes during Ramadan were used by 62% of physicians with notable inter-countries differences. After risk assessment, 33 of patients were low risk and 31 were at moderate risk. And data indicated that many patients who are considered to be at high or very high risk of adverse event still fast during Ramadan, despite the ADA recommendation that those at high risk should be advised against prolonged fasting. A column chart here that we can see in front of us, that there is a variation between countries in the use of guideline or recommendations by physicians for the management of type 2 diabetes in patients who fast during Ramadan. As we can see here, France has the lowest percentage of using the guideline recommendation during Ramadan, and the highest were in Indonesia and Kuwait and Saudi Arabia. The majority of patients in the CREATE study were received oral hypoglycemic agents. A change in diabetes regimen in preparation for Ramadan was reported for a total of 39% of patients, and during Ramadan, at least one episode of hypoglycemia was reported by 8% of the patients with type 2 diabetes, compared with only 5% before Ramadan, and 47% of hypoglycemia episodes necessitated to cessate or to break the fast. DAR Global Survey, we're talking about the type 2 diabetes, compare between elderly patients and more younger patients who are less than 65-year-old. The elderly patients were having the higher rate of having to break the fast. The risk factor was hypoglycemia and also hyperglycemia, and more requiring acute hospital care like emergency department or hospital admission. On the other hand, the younger patients has less requiring acute hospital care. And older patients have longer duration of diabetes that will increase the risk of complication during Ramadan and comorbidities and mortalities. Or on the other hand, younger patients have less duration of diabetes and less complication, and older patients has higher rate of insulin use, and also recurrent hypoglycemia awareness will lead to hypoglycemia and awareness. On the other hand, younger patients with type 2 diabetes who were less than 65-year-old has less hypoglycemia. A specific emphasis must be placed on pre-Ramadan diabetes education and SMBG with appropriate adjustment in the glucose-lowering medications. This will help to allow older adults to safely fast if they so choose to participate in fasting during Ramadan. Darmina for type 2 diabetes, the characteristic and pattern of the care for type 2 diabetes in the Middle East and North Africa region during Ramadan as a prospective study. And this is the table to compare between the four studies that we've talked about. We can see here the majority of the population for type 2 diabetes were with EPIDIAR and DAR global survey, and the fasting for more than 15 days and completing the month of Ramadan were with CREED and DAR global survey. And it's evident that rate of fasting have remained stable across these studies spanning almost 2 decades, with more than 4 out of 5 people intending to fast during Ramadan, and with a mean duration of fasting of 27 days. And in both study for CREED and for global survey, these 2 studies reported fasting post-Ramadan in the month of Shawwal, and found that more than quarter of survey participants perform this non-obligatory fasting. I mean by that the al-ayyam al-sitt in Shawwal, and the mean number of days was found to be 6 days. And here's a continuation of the previous table to compare between the risk of complication, the macro complication, the micro complication of the patients who fasted in Ramadan for type 2 diabetes. So as summary, we know that the epidemiology of diabetes and Ramadan is very huge topic to talk, but we try to make it summarize as much as we can. So as a summary, we can conclude from our lecture for today that the importance of effective guidelines for the management of diabetes during Ramadan fasting is clear, as many recommendations are based on expert opinion rather than clinical evidence. However, in recent times, a significant number of studies have been published in the area of diabetes and Ramadan. Fasting in Muslim populations is not limited to Ramadan, and guidance can be supportive throughout the year. And there is evidence of age-specific differences in fasting practices and outcome in people with type 1 and type 2 diabetes. And those are my references, and كل عام وانتم بخير, and thank you very much for being with us today.
Thank you, Dr. Nida, for this stop sharing. Thank you, Dr. Nida, for this nice lecture. I want to introduce the second speaker, Dr. Ashjan Arrogi. She is a consultant endocrinologist and internist at Hera Diabetes and Endocrine Center. She will talk about the patient risk stratification during Ramadan. Which patient at risk to fasting Ramadan? Which patient safely fasting Ramadan? Dr. Mendel?
Okay.
Can you help me technical?
Yes. Can you stop sharing, please, from point, or give me the co-host?
Okay. I will start mine.
عليكم ورحمة الله وبركاته. Thank you for organizing this beneficial course every year about Ramadan and diabetes. Inshallah, I will talk about the risk stratification for diabetic patients who wish to fast Ramadan safely. As you know, Ramadan is one of the 5 pillars of Islam. Fasting is obligatory for all healthy Muslims who have reached puberty. But some people are exempted from fasting duty. People who are in trouble or ill or live with a medical conditions that put them at risk during fasting, like a patient with diabetes. Epidemiology from the epidemiological studies found that a good numbers of diabetic population are fasted Ramadan at least for 15 days. In the landmark epidemiological study EPIDIAR that's conducted in 2001 found that around 42% of type 1 and 78% of type 2 are fasted for at least 15 days. And notes there is a hypoglycemic risk more frequent during Ramadan than compared with other months of the year. In 2010, CREED study, which is conducted in type 2, found that 94% with type 2 fasted for at least 15 days, and around 64 of the participants they able to fast Ramadan fully. In 2016, in Darmena, which is a epidemiological study about diabetes in Ramadan, Middle East, and North Africa, the study revealed around 86% of type 2 and 72% of type 1 are able to fast at least 15 days. The percent or population of type 1, as we noticed, is increasing. Also, the surprising is 48% of type 1 able to fast Ramadan fully. Benefit of fasting Ramadan. As you know, Ramadan fasting is kind of a form of intermittent fasting. And you know, the intermittent fasting life style of the diet point of view is noticed in many studies that improve the weight, the body weight, center obesity, adiposity, and glycated hemoglobin. Also, the intermittent fasting found that it improved the insulin sensitivity and cardiovascular markers. Fasting of Ramadan found to improve the both physical and mental well-being. Before we go to the risk stratification, I will take you slightly in the pathophysiology in fasting Ramadan. In the feeding state, as you see, the patient is eating, the glucose level in the circulation is increasing, which is stimulate the pancreas to release insulin and to suppress the glucagon secretion. This is what happens in the healthy individual. Insulin secretion is suppress the hepatic output of glucose and improve the glucose reuptake or uptake by the peripheral tissue and store of this glucose in form of glycogen. In the fasting state, in the healthy individual, the glucose level in the circulation decrease. So this is stimulate the glucagon secretion from the pancreas and suppress the insulin secretion at the same time. The suppression of insulin led to stimulate hepatic secretion of glucose by stimulation of glycogenolysis and gluconeogenesis. Also, this is causing suppression the uptake of glucose by the peripheral tissue like a muscle and other tissue. With the prolongation of fasting, after the depletion of the glucose stored from the hepatic tissue and other organs like kidney, the adipose tissue start to be metabolized, the lipolysis occur, and there is a release of ketone body causing ketogenesis. What happened in diabetic patient? Diabetic patient in the fasting state will have the exaggeration of the normal physiology. More less due to absence of insulin, due to insulin deficiency or insulin resistant, they have insulin deficiency, so more glucose output from the peripheral tissue, less glucose uptake, more risk of hyperglycemia. In presence of unadjusted anti-diabetic medication also will cause worsening of hypoglycemia, less insulin, more ketogenesis production. At the same time, they are at risk of hypoglycemia because of presence, patient is fasting and presence of anti-diabetic medication which is not adjusted, either oral hypoglycemic or insulin, and at the same time, low glucagon level, especially in type 1, put him at a risk of hypoglycemia. So difficult to control to improve the balance of glucose in diabetic patients. So those patients are at high risk of, as I said, from the pathophysiology of hyperglycemia due to absence of insulin, worsening of with the fasting, with low insulin level, diabetic ketoacidosis risk is high, more hyperglycemia, presence of hyperglycemia, osmotic diuresis is worsening, patient fasting in the long duration hours, like in our country, in hot and humid air, causing dehydration and put him at risk of thrombosis. Of course, hypoglycemic risk is high in the fasting state due to presence of anti-diabetic medication, unadjusted and low glucagon level, especially in type 1. How diabetic patient able to fast Ramadan safely? By pre-Ramadan assessment and education. It's found in many studies, it's improve or reduce the incidence of hypoglycemia and other complications. Pre-Ramadan diabetic education, it's important to highlight 5 important corner or item. First, risk quantification, importance of self-managing of blood glucose, advice regarding the diet and exercise during Ramadan. Also in the pre-Ramadan education, you should teach the patient about the medication adjustment and teach the patient about the hyperglycemic crisis symptom, hypoglycemic symptom, and when important to break the fast. Pre-Ramadan counseling and clinical assessment ideally to be done 6 to 8 weeks before Ramadan. This kind of counseling is considered as a shared decision between the healthcare provider and the patient, depending on the patient's criteria and the treatment options, considered as a kind of individualized plan. In the era of COVID pandemic, structured education classes to both healthcare provider and people with diabetes can be easily done through telecommunication as we are doing now. So we go to the risk stratification. Since 2005, the American Diabetes Association recommendation for the patient with diabetes who wish to fast Ramadan, they categorize them into 3 main categories called 3 traffic light system. To the red category, which is the high category, high risk, very high risk category, the yellow light, which is the high risk, and the green, they are moderate to low risk. This is categorization followed by IDF-DAR in the 2016. Until recently, we are using this categorization. This category or this is system depends on the patient criteria. So in first category, which is the red light, very high risk, in presence of one only of the following criteria, like severe hypoglycemia within 3 months, DKA within 3 months, HHS within 3 months, presence of recurrent hypoglycemia, hypoglycemic awareness, poorly controlled type 1, acute illness, pregnancy with pre-existing diabetes or GDM and insulin, CKD on dialysis or advanced stage, and advanced macrovascular complication, elderly with ill health. Category 2, the yellow light, which is high risk, presents one of the following. Type 2, poorly controlled in MDI. Type 1, well controlled, they consider them as high risk and they advise not to fast, which is considered slightly non-convenient for diabetic patients, especially type 1. And most of these patients in this category, even they insist to fast and they fast against your medical advice. In last stage, considered as a moderate to low risk. Usually they are type 2 with an oral medication and or basal insulin. The new risk categorization is replacing the old one, which is endorsed in the IDF DAR 2021. It depends on the risk assessment by the scoring calculation. So the risk calculation depends on the 14 items, more flexible. So you calculate the risk, and then after the calculation of the risk, the score, if it is more than 6, put the patient at high risk. If the score less than 3, put the patient in the low risk. If the score between 3.5 to 6, put the patient in moderate risk. We talk about these items in details. The first item is diabetes type. If the patient type 1, will take 1 in the scoring system. If he is in type 2 patient, 0 score. Duration of diabetes is very important. If it is more than 10 years, we'll take 1. If the duration less than 10 years, we'll take 0. Presence of hypoglycemia. Hypoglycemic awareness is very high risk. Patient will take 6.5. Recent severe hypoglycemia, 5.5. Multiple weekly hypoglycemia, 3.5. Hypoglycemic less than 1 time per week, 1. If no hypoglycemia, we'll take 0. Level of glycemic control, if it is poorly controlled, more than 9.2. If the patient is moderately controlled from 9 to 7.5, we'll take 1 in the risk in the score. And if it is fair control less than 7.5, we'll take 0. The type of treatment, very important. The patient on the complex regime like MDI, will take 3. If the patient on insulin pump, will take 2.5. If the patient taking once daily mixed insulin, 2. If the patient taking basal insulin, 1.5. If the patient glabinlamide, will take 1 because of high risk of hypoglycemia. If the patient in other sulfonylurea, will take 0.5 in the scoring system. And if the patient on other medication other than sulfonylurea or insulin, will take 0. If the patient cooperative doing SMBG frequently, will take 2. If he is not conducting SMBG frequently, will take 2. If the patient conducted SMBG but not optimally, will take 1. And if he is doing cooperative doing SMBG frequently, will take 0. Presence of acute complication recently within 3 months, like a DKA or HONC, will take 3. Within 6 months, we'll take 2. Within 12 months, we'll take 1. And if no DKA, we'll take 0. Presence of macrovascular complication, if it is unstable, we'll take 6.5. If stable, we'll take 2. Presence of renal complication, advanced renal dysfunction like GFR less than 30 will take 6.5 and so on. Presence of pregnancy, and if it is pregnant not within target, will take 6.5, very high risk. If it is within target, will take 3.5. Elderly with cognitive dysfunction will take 6.5. If he has no home support, will take 3.5. Physical labor, also the importance of physical activity. If he has a high intense physical activity, if he has a moderate, will take 2. The experience of previous Ramadan, very important. If it is negative experience, will add 1 score. If it is positive experience, will add 0. And the fasting hour duration, if it is more than 16 hours, will take 1. So after that, we are categorize the patient depending on the calculating the score. If it is more than 6, we put the patient at high risk. If it is Less than 3 will put him at a low risk, in between or moderate risk. What is the recommendation for high risk? The medical recommendation: fasting is probably unsafe for individuals in the high risk and high risk for developing complications. So we recommend those people not to fast. But actually, many patients with high risk insist to fast. So if he insists to fast, you need to take him, educate him more frequently, monitor him closely, in addition to the adjustment of medication. Moderate risk people, the fasting safety is uncertain in those categories when the risk is between 3.5 to 6. So the decision of fasting or not to fasting, it's a personal decision after taking in consideration the patient risk and in consultation with the healthcare provider. If the patient wants to fast, you need to follow him closely. You need to teach him about the adjustment of medication, importance of SMBG and frequent blood sugar monitoring, and teaching him importance of to break fast whenever needed. If the patient wished not to fast, if he wants not to fast because he fear of the complication, he cannot, you can allow not to fast and support his decision. Of course, if the high risk and moderate risk patient insists to fast, should receive structural education and be followed by qualified diabetic team, check blood sugar frequently, adjust medication as per recommendation, be prepared to break the fast in case of hypo or hyperglycemia. Of course, you should teach the patient when important to interrupt the fasting if there is hypoglycemia less than 70, hyperglycemia more than 300, symptom of hypo or hyperglycemia, or presence of symptom of acute illness. Finally, low risk, if it is less than 3, those individuals they are low risk of complication and able to fast with good blood sugar monitoring and adjustment of medication. IDF DAR practical guideline is approved by the Mufti of Egypt, and this is schedule showed the summary of the medical and religion risk score recommendation. The low risk less than 3 medical recommendation is fasting is probably safe. The religion recommendation fasting is obligatory. For moderate risk, fasting safety is uncertain. This is the medical opinion. The religious opinion, fasting is preferred, but patients may choose not to fast if they are concerned about their health after consulting the doctor. If the patient want to fast, they must follow the medical recommendation, including regular blood glucose monitoring. And he can break the fast at any time if needed. High risk group, more than 6, the fasting is probably unsafe and advice against fasting. This is from religious recommendation. As you see here, there is an Arabic opinion from the Mufti of Egypt is found in the latest guideline from IDF DAR 2021. You can go and read it. Finally, the management of people with diabetes who fast during Ramadan has generally based on expert opinion rather than medical evidence. Individualized risk assessment remains the most appropriate method. This risk stratification should be conducted annually to review the level of risk in advance of Ramadan. This risk score is more flexible, allowing physicians from all specialists able to categorize their patients more easily and safely. Collaboration between the medical and religious experience is very important and make the patient follow the advice and feel not guilty if he not fast. As mentioned before, fasting during Ramadan became obligatory from the age of puberty, but those individuals that are unhealthy can be exempted. In circumstances where any missed day can't be compensated after Ramadan, fidya can be paid. Thank you for attention.
Thanks, Dr. Ashjan, for the informative lecture. It was a good summary. So now is the time to go for the next lecture. The next presentation will be about pre-Ramadan education and self-monitoring blood glucose. We know that it is very important to go for self-monitoring blood glucose because to avoid any hypo or hyperglycemia. So special guidelines was introduced in this category. This lecture it will be presented by Dr. Salwa Hausawi. Dr. Salwa is a consultant endocrinologist at Hira General Hospital. So floor for you, Dr. Salwa.
السلام عليكم ورحمة الله وبركاته. أسعد الله مساءكم بكل خير. اللهم بارك لنا في شعبان وبلغنا رمضان. It's my pleasure to be with you today and great thanks for the organizing committee. I will talk today about the pre-Ramadan education and self-monitoring of blood glucose. The content of my presentation will be the objective and target of Ramadan focus education, self-monitoring of blood glucose, the Ramadan nutritional plan for people with diabetes, and I will talk also about the exercise, benefit of Ramadan focus education, education through technology, the last is the challenges and solution of diabetes during fasting and COVID-19. The objective of Ramadan focus education is to raise the awareness of risk associated with diabetes and fasting, to provide a strategy to minimize them. The education should be simple, engaging, and delivered in a cultural, sensitive manner by a well-informed individual. Actually, the individuals who have received Ramadan focused education were reported to be better at following Ramadan diabetes management recommendation. The pivotal epidemiology of diabetes and Ramadan study demonstrated that approximately only 2/3 of people with diabetes have received a recommendation from their healthcare professionals regarding the management of their condition during Ramadan. And the third study, which is a multi-country retrospective observational study of the management and outcome of type 2 patients with diabetes during Ramadan, conducted in 2010, showed that the 96% of physicians provided advice to fasting individuals, although only 63% based on the guideline recommendation. The studies have revealed that only 30 to 67% of physicians use the Ramadan focus education program, and only 47% of the patients attended such programs. So, more widespread targeting education is necessarily prior to fasting. The pre-Ramadan education is crucial for safe fasting during Ramadan, and should be primarily targeted at people with diabetes and healthcare professionals, and it's also should target the wider public who serve as the support network for people with diabetes. The educational targeting the general public should aim to raise the awareness of the issue and misconceptions surrounding the diabetes and Ramadan, and emphasize on the importance of maintaining a good glycemic control during fasting. In addition to medical advice, religious regulation should be included. Why? Because the religious and community leader are a valued and trusted member within the targeted community. Among people with type 2 diabetes, culture-appropriate health education has proven more effective than usual health education in improving the glycemic control and the knowledge about diabetes and its management. So the culture barrier should be eliminated, which including the patients who don't practice healthy behavior, don't care about their health. Personal health is the most important priority for each family member. Biomedicine is right. Science is the only appropriate basis for practice. Traditional beliefs should be changed rather than built up. Everyone understands the concept of chronic illness. People should and will follow direction given by health practitioners Adherence failure is a patient problem. Patients have autonomy except with regard to adherence. Healthcare is available and accessible to all. In this flowchart for the pre-Ramadan assessment, show that education is important to effectively manage the diabetes during the holy month of Ramadan. The main area of diabetes education should be provided prior to Ramadan are the risk quantification and exemption and removing the misconception, blood glucose monitoring, when to break the fast, and physical activity and exercise advices, fluid and dietary advices, medication adjustment, test fasting, recognition of hypo and hyperglycemic symptoms. So, all people with diabetes should attend a pre-Ramadan assessment with their healthcare professionals 6 to 8 weeks before the starting Ramadan. In the assessment, detailed medical history should be taken, and it should include discussion about the aspect of diabetes and ability to self-manage, presence of comorbidities, the individual prior experience in managing diabetes during Ramadan fasting, the individual ability to self-manage diabetes. Other aspects include the risk of fasting, and then they can be stratified according to their potential risk into low, moderate, and high risk. The main aim of pre-Ramadan visits are to provide individuals with diabetes with modified nutritional plan that improve glycemic control while fasting during Ramadan. Provide individuals with medical nutritional plan that may help overweight and obese people to success and safely lose weight during Ramadan. Adjust anti-diabetic medication in line with the individual changes in the nutrition that can occur during the Ramadan fasting. Encourage proper and safe level of exercise and physical activity while fasting during Ramadan. Provide education to help individuals recognize the warning symptoms of dehydration, hypo and hyperglycemia, and possible complication. Enforce the importance of blood glucose and body weight monitoring during Ramadan. Actually, the frequency of SMBG depends on the many factors, include the type of diabetes and current medication, but it should be carried out regularly by all. For those with moderate or low risk, once or twice a day is enough. Those at high or very high risk should have several time blood glucose checking. Actually, the individual on insulin or in sulfonylurea may choose to monitor their blood glucose level more frequently because of the increased risk of hypoglycemia. It's important for all people with diabetes to measure blood glucose level after iftar to detect postprandial hyperglycemia. Also, individuals should check their blood glucose level whenever they experience symptoms of hyper, or feeling unwell. And they should understand when they have immediately to break their fast. Actually, in this figure, this is an example of SMBG guide to check blood sugar in sahur time, morning time, in the midday, and mid-afternoon, also in the iftar time, and I mean 2 hours after iftar, anytime patient experience symptom of hyper or hypoglycemia or feel unwell. There is a misconception by some Muslim community that breaking the skin for blood glucose testing is invalidated the Ramadan fasting. It should be strongly emphasized in the educational program that this is not the case. An individual should be provided with the tool and knowledge to carry out self-monitoring of blood glucose. Here, we will talk about the attitude and habit of patients with type 1 diabetes during fasting Ramadan. In this prospective cohort study of patients with type 1 diabetes who were in insulin pump or multiple daily insulin injection regimen, those patient questionnaires regarding the frequency of self-monitoring of blood glucose. The SMPG was performed 4 times or more daily by around 57% of pump group compared to 24.5% of MDI groups, with a significant difference with p-value of less than 0.001. Actually, a higher number of patients in both groups performed the SMPG 2 times or more daily, with more patients doing so in the insulin pump group. This figure shows the difference between the two groups in the favored time of daily performing SMPG. Actually, the favored time was 2 hours post-iftar and 2 hours post-sahur, which was more favored in the MDI group than the pump group. Okay, the main aim of medical nutritional therapy during Ramadan is to ensure that the individual with diabetes consume an adequate amount of calories with balanced proportion of macronutrients during the non-fasting period, which is sensitive to sun to down, to prevent hypoglycemia during the fasting period. Individuals with diabetes equally distributed their carbohydrate intake among meals to minimize postprandial hypoglycemia. To ensure also the individual with diabetes and healthcare professionals giving consideration to comorbidities such as hypertension and dyslipidemia when formulating the medical nutritional therapy plan. Actually, there are many diabetes-related risks which can be minimized through proper nutrition, include hypoglycemia, especially during the late period of fasting before iftar, severe hyperglycemia after each of the main meal, dehydration, especially in the countries with longer fasting hours and hot climate, significant weight gain during due to an increased caloric intake and reduction in the physical activity, electrolyte imbalance, acute renal failure in individuals prone to severe dehydration, particularly the elderly and who have a renal impairment. Actually, there is a dramatic change in the dietary pattern in conversion to the other during Ramadan in the conversion to other months of the year. And health issue can arise due to improper eating habits and reduce the physical activity. Here we have an example of unhealthy nutrition habit that commonly developed during Ramadan, which include the consumption of unusual large meal at iftar containing 1,500 calories, the consumption of significant amount of high processed carbohydrates and sugar at iftar or in between the iftar and sahur time, eating desserts loaded with sugar after iftar, the consumption of large portion and frequently eating snacks between the two main meals, eating at fast speed, which frequently lead to overeating, skipping meals at sahur or consuming meals for sahur too early, the consumption of large portion of high glycemic index carbohydrate at sahur, eating fried food too frequently, changing the physical activity and sleeping pattern. Actually, this table summarizes the dietary recommendation for people with diabetes fasting Ramadan. Actually, it's recommended that to ensure that the meal are well balanced, containing 45% to 50% of complex carbohydrates, for example, barley, wheat, oat, milk, and semolina, beans and lentils, and also should contain 20 to 30% of protein, 35% fat, preferably mono and polyunsaturated. Also, it should include a low glycemic index, high fiber food that release energy slowly before and after fasting. For example, granary bread and beans, rice. Include plenty of fruit, vegetable, and salads to minimize the food that are high in saturated fats. Avoid sugar desserts. Use a small amount of oil when cooking. For example, olive oil, canola, or rapeseed. Keep hydrated between sunset and sunrise by drinking water or other non-sweetened beverage. And they should also avoid caffeinated and sweetened drink. Actually, weight gain during Ramadan should be avoided. People with type 2 diabetes who are overweight or obese may find that Ramadan provides a good opportunity to lose weight. And this may significantly improve the glycemic control and also may reduce the cardiovascular risk. An optimal targeted is a modest and gradual weight reduction of 0.5 to 1 kg per week to achieve a weight loss or avoid a weight gain. Actually, the intake of calories should be controlled and kept within a specific target based on the height and gender. For example, in a woman with less than 150 cm tall, 1,200 kilocalorie can result in weight reduction. Also, the taking of 1,500 kilocalorie, it's resulting in weight maintenance for women less than 150 cm tall and weight reduction for women more than 150 cm tall. And the meal containing 1,800 kilocalorie result in weight maintenance for women more than 150 cm tall and weight reduction for men. The 2,000 kilocalorie can cause a weight maintenance for women more than 150 cm tall and for the men. This is an example of Ramadan nutrition plate of Sahur and Iftar meal. This meal provides a 500 kilocalorie with 45% of carbohydrates and 20% of protein and 35% of fat. Okay, what about the exercise? Actually, the rigorous exercise should be avoided, particularly during the last hours of fasting. Individuals are more likely to achieve lower hemoglobin A1C and reduce the body weight when more nightly prayer are performed. Okay, on those on lifestyle, they should modify frequency and intensity of their physical activity. The patient with type 2 diabetes on oral medication or insulin should avoid exercise before iftar. Those with type 1 diabetes, actually the personalized decision and avoid intense exercises recommended for them. The preferred mode of exercise are to maintain a normal daily routine, walking stationary, cycling, and perform a Tarawih prayer. The exercise timing, the preferable time is 2 hours after iftar and after night, and also during tahajjud prayer. Actually, as a general recommendation, the SMPG needed before, during, and after exercise in very high and in very high and high risk individual. Also, people should ensure adequate hydration before and after exercise. The Ramadan focused diabetic education provide information on how to use certain type of advice such as insulin pens, meters, CGM, and pump. Role of education in pre-Ramadan, role of educator in pre-Ramadan diabetes education is to provide Ramadan focused guidance on how often to monitor their blood glucose during the day, the importance of looking out for sign of low blood sugar, how to alter during dosage and timing, diet and fluid intake, the importance of avoiding strenuous physical activity. Actually, in this retrospective interview, which interview 1 month after Ramadan for a 1,008 type 2 diabetes patients who were offered a culture-based pre-Ramadan education program in addition to standard of care 2 months before Ramadan. Compare the fasting experience of pre-Ramadan education program attendees with those who merely received the standard of care. It showed that more hemoglobin and weight percent reduction observed in those who received the pre-Ramadan education program in compared to those none. The same study showed more hemoglobin A1C and weight percent reduction in those who performed the prayer more than 20 nights compared to those who didn't perform the Taraweeh prayer. Okay, so the the Ramadan focused education provide a greater glycemic control, better self-monitoring of glucose and treatment management, sustained motivation in adhering to guidance, greater empowerment to fast safely during Ramadan. Okay, when to break the fast? All individuals should break their fast if the blood sugar less than 70, blood glucose more than 300, or symptom of hypoglycemia and hyperglycemia, dehydration, or acute illness occur. And they should be aware about the hypoglycemia symptoms, which include trembling, sweating, chills, palpitation, hungry, altered mental status, confusion, and headache. And also the hyperglycemic symptoms, which are extreme thirst, hunger, frequent urination, fatigue, confusion, nausea, vomiting, and abdominal pain. What about the education through technology? Telephone and mobile phone are convenient mode of communication and may become a standard method for future consultation. The teleconsultation, telemedicine, and telemonitoring have all been identified as an effective mode of managing the needs of people with diabetes and have been shown to enhance education and SMBG online education courses via the smartphone. Application and short messages, text could be preferred mode of education, individual about their diabetes and interacting directly with a healthcare provider. These can also help reduce the need for making multiple visits to clinics. Actually, only few studies have examined the potential of telemedicine in reducing hypoglycemia, which is the most important issue for type 2 diabetic patients. In this study, 12 weeks cluster randomized control trial comparing the telemedicine with the usual general practice carrying among patients with type 2 diabetes who wish to fast during Ramadan. It showed that at the end of the Ramadan period, the reported symptomatic hypoglycemia were lower in the participants in the telemonitoring in compared to those usual care group. And only 2 participants in the telemonitoring group and 6 participants in the usual care group reported symptomatic hypoglycemia with blood sugar less than 3.9. The challenges which can we face during fasting and COVID-19 are disruption of pharmacological supply, loss of access to healthcare, compared to the technology usual care group. And only 2 participants in the telemonitoring variation and 6 participants in the usual care group reported symptomatic hypoglycemia with blood sugar based on 3.9. Teaching and practicing, conducting religious gathering, which ensuring safe precautions during and holding prayer after approval. The solution which can be used are secure, stable stock of medication, virtual consultation, volunteer help, telephone consultation, regular SMPG, prepackaged food, and safe distancing religious leader on digital platform, WHO risk assessment tools, advocacy by religious organization, and liaison with the local health authorities, social distancing at entry and exit points, a smaller, shorter, and periodic prayer, face mask and hand washing facility, personal prayer wraps, and not forbidding topical medication. In summary, pre-Ramadan education is a key component of safe fasting during Ramadan for people living with diabetes and should target people with diabetes, healthcare provider, and the general public that serves as the support network. A structured education program should include information on risk quantification, removing misconception, SMPG, diet, exercise, and physical activity, medication adjustment and dose testing, recognition of the symptom of complication, and when to break the fast to avoid harm. The beneficial effect of pre-Ramadan education on adequate nutrition and meal intake, adjustment, medication dosage, and healthy lifestyle behavior can guide individual to fast in a safe and healthy manner. The nutrition plan helps people with diabetes plan daily caloric target that may help them maintaining their body weight if they are lean or lean, or to lose weight if they are overweight or obese. Actually, it provides a meal plan within the target caloric level based on individual need and tailored for use in different countries. Glucose monitoring technology play a key role in managing diabetes, predicting severe hypoglycemia and achieving hemoglobin A1C targets. Studies have demonstrated clear benefit of Ramadan-focused education program on glycemic control, weight loss, and improving the risk of hypoglycemia, potentially even in higher risk individuals.
Thank you, Dr. Salwa, for this nice lecture. I want to welcome Dr. Muhammad Aish with us. You are welcome, Dr. Muhammad. He will present, he will have talk for 10 minutes for Ramadan and diabetes. Dr. Muhammad, you can share now.
Thank you, Dr. Humaid, but I am unable to share my screen, Dr. Humaid. If you could enable me, please.
Okay, I will enable you. Yeah, you can.
Okay, thank you, Dr. Humaid.
Okay.
Now you can see my screen, right?
Yes, yes, clear.
Okay. Thank you all for allowing us to have this meeting today. This is me, Mohammed Aish, Medical Science Liaison from Boehringer Ingelheim, responsible for metabolism and heart failure. Our topic today will be an interesting topic. It's about type 2 diabetes as a cardio-renal metabolic complex disease. What are the content for our agenda today? Introduction to the interrelated cardio-renal metabolic system. How can we change the outcome of the cardio-renal metabolic conditions, and some practical advices on the SGLT2 inhibitors. As you all know, I want to remove this, please. Oh, yes, okay. As you know, the cardio-renal metabolic system are interrelated to each other. Heart is the most metabolically demanding organ. the metabolic system, responsible for regulation of energy metabolism by liver, pancreas, and fat, and is essential for a healthy function of organs, especially heart and the kidney. The kidney itself it play an important key role in the glucose and volume homeostasis and the blood pressure regulation. So the CRM system are interrelated to each other. Any acute or chronic dysfunction in heart, liver, or kidney will induce the dysfunction in the other organ. And each dysfunctional organ has the ability to initiate and perpetuate the disease in the other organs through a hemodynamic, neurohormonal, and immunological feedback pathway. One of the conditions that affect these three systems are type 2 diabetes. Actually, type 2 diabetes is a risk factor for the disease related to the cardiac and the renal system itself. Here is the journey for type 2 diabetic patients. It's really a typical journey. If we're going to have a type 2 diabetic patients who is having a risk factor like diabetes, hypertension, obesity, and dyslipidemia, all these risk factors are intertwined together and start to perpetuate and initiate the diseases either in the cardiovascular system or the renal system or even the diabetes and metabolic system. They start showing us by affecting the endothelial dysfunction, affecting the cardiovascular system. Then arteriosclerosis start showing up, which is potentially start to affect and causing a major damage to the coronary artery disease. Then after a time, to start to show a major cardiovascular event like myocardial infarction and stroke, followed affecting to causing remodeling to the cardiac system and affecting the left ventricle remodeling. Then it will end up by having heart failure and the cardiovascular death, which is by the end something that we need to protect and to prevent from causing it to the type 2 diabetic patient. Parallel and simultaneously, it affecting the renal system, starting by showing up having a microalbuminuria, followed by macroalbuminuria, then CKD disease, and finally end with end stage kidney disease. So as a type 2 diabetes, we must think of the concept of a condition like CRM system, which is a cardiac metabolic condition. We're going to protect the patient not only by controlling the HbA1c, but also by controlling the other system like the cardiac and renal system in parallel with the metabolic system. So if the patient is having a metabolic dysfunction, the metabolic abnormality, it will definitely affect the cardiac and renal disease progression. Patient having a metabolic disease, he will start having hyperglycemia, dyslipidemia, and insulin resistance. This will end up by affecting the renal system by causing fluid retention, albuminuria in different grades, and will end up by having declining in the kidney function itself. Abnormality in the energy system or the metabolism system will affect the heart by having arteriosclerosis, vascular dysfunction, and finally will end up by having a heart failure for the patient. If we look it from the cardiac perspective, if the patient is having a cardiac abnormality, this will affect both the metabolic and the renal system. Patient with abnormalities in the cardiac condition will have neurohormonal activation, hypoperfusion, and volume overload with increasing the arterial resistance. This will end up by affecting the metabolic system by causing insulin resistance and decrease in the free fatty acid and dyslipidemia. Abnormalities in the cardiac will definitely affect the renal system by having hypertension, albuminuria in different grades, and will end up by declining in the kidney function itself. If we look from the perspective of the renal dysfunction, patient with abnormality in the renal function will have activation of the ROS and the central nervous system, will have sodium and fluid retention, will have hypertension and oxidative stress. This will end up by affecting the cardiac also and the metabolic system by increasing the insulin resistance and increasing the glucose level beyond its normal level. Affect the cardiac system by also having arteriosclerosis, vascular dysfunction, heart failure, and will end up by ventricle hypertrophy. So As a conclusion, if we look at from the concept of this Venn diagram, type 2 diabetes, cardiovascular disease, and the coronary heart disease, if patients intersect in all these circles by having type 2 diabetes, cardiovascular, and the coronary kidney disease, this will further reduce the life expectancy in patients. So type 2 diabetes as a standalone disease itself, 55% of the patient are type 2 diabetic with non-alcoholic fatty acid liver disease. Over half of the patients with type 2 diabetes are reported to be obese. Type 2 diabetes as a standalone disease itself reduces the life expectancy by 6 years. Okay, if a patient is having type 2 diabetes and cardiovascular disease or heart failure, actually, 1 in 3 patients with type 2 diabetes have a cardiovascular disease. There is a 2 to 5-fold increase in the risk for hospitalization for heart failure for a patient with type 2 diabetes. Cardiovascular disease is the leading cause for mortality in patients with type 2 diabetes. Okay, what if we took the type 2 diabetes away from the picture and look from the perspective for patient with heart failure or cardiovascular disease with a chronic kidney disease? About 67% of the patients with heart failure are estimated to have a chronic kidney disease, and the risk for the cardiovascular death increase as the kidney function decrease. And actually, about 25 to 80% with heart failure and the chronic kidney disease are at high risk of mortality. And this is logic because the patient of heart failure and chronic kidney disease is not receiving the optimum treatment, and for sure the mortality rate will going to be increased. Moving forward to the patient who are type 2 diabetic patient and have a chronic kidney disease, chronic kidney disease affect up to 40% of the patient of type 2 diabetes. Patient with type 2 diabetes and chronic kidney disease, their life expectancy reduced by about 16 years, which is 10 years more than type 2 diabetes alone. So how can we change the outcome for the cardiorenal metabolic condition? And this is really the recommendation from the ADA and ECC guidelines, focusing on the multifactorial management of chronic cardiovascular risk factor, as well as establishing the standard of care for patients with type 2 diabetes. Start glucose lowering target are individualized for many patients, less than 7% HbA1c. Different treatment options are available, like metformin and SGLT2 inhibitor and GLP-1 receptor agonist. Blood pressure lowering also target are individualized. LDL lowering and individualized diet and lifestyle change for the patient. So these are the risk stratification as per ECC guidelines. What's meant by moderate risk? Moderate risk is a young patient, either type 1 less than 35 years or type 2 less than 50 years with diabetes mellitus duration less than 10 years. High risk patient is a patient with diabetes mellitus duration more than 10 years without a target organ damage. Very high risk patient is patient with diabetes mellitus and established cardiovascular disease with target organ damage or 3 or more major risk factor. So the patient you are seeing in the clinic are most probably located in the high risk and very high risk patients. So we must think from the concept of the cardiorenal metabolic concept to protection, either than alone controlling the diabetes alone. So if we come back again to our Venn diagram where type 2 diabetes, cardiovascular disease, or renal disease, to see where is the glucose lowering agents are targeting, here SGLT2 inhibitor is one of the molecules that is targeting the 3 conditions, the cardiac protection, renal protection, and metabolism control. The metabolic effect of the cardiorenal and the cardiorenal metabolic effect of SGLT2 inhibitor is reduction of the major adverse cardiovascular event, reduction of the cardiovascular death, reduction for hospitalization for heart failure, protection of the kidney by improving the heart kidney outcome, reduction of the albuminuria, and protection from the EGFR worsening. So EGFR, so this 3 condition protection and controlling will be achieved by using this group of medication. If we look in deep to the SGLT2 inhibitor in terms of the cardiovascular death, only empagliflozin in the empiric outcome showed a benefit regarding to the cardiovascular death reduction by 38%, and only the liraglutide from SGLP1 receptor showed a benefit in the cardiovascular outcome trial. The major adverse cardiovascular event reduction, the EMPA and the canagliflozin showed a reduction in the major adverse cardiovascular event. The hospitalization for heart failure, it seemed to be a class or something related to the class of SGLT2 inhibitors, and it is a unique added point for this category of group of treatment of lowering agent for diabetes. Again, the heart kidney outcome is something unique and showing a significant relative risk reduction regarding to the SGLT2 inhibitors. And the composite kidney outcome, again, also it is something unique about the SGLT2 inhibitors. As a conclusion and summary for the cardiovascular outcome trial, only EMPA in cardiovascular, this is exclusive for empagliflozin in SGLT2 inhibitors and liraglutide and GLP-1 receptor agonists. Hospitalization for heart failure is something unique for the SGLT2 inhibitor as a group. Also, hard kidney outcome, albuminuria is a unique for the SGLT2 inhibitor as a group for treatment of type 2 diabetes. As a mechanism of action, how SGLT2 inhibitor is affecting or protecting the cardiorenal metabolic system, we have three hypotheses or three mechanisms of action for SGLT2 inhibitor showing the benefit on CRM system, diuresis and glucose excretions and natriuresis. This will end up into having an intermediate effect by decreasing the myocardial sodium content due to the inhibition of sodium hydrogen exchange receptor, decrease and reduction in the intraglomerular pressure, reduction of left ventricular wall stress and left ventricular wall mass, decreasing the afterload and improving the vascular function, reductions the preload with decreased volume interstitial volume, decrease reduction in the inflammative oxidative stress. This will end up by increasing the hematocrit and increasing the bioenergetics, and will effect end up by having a protection in the cardiovascular event and reduction in the cardiovascular event, reduction in the kidney disease, reduction blood pressure, body weight, and HbA1c, which are the CRM concept protection and improvement we are looking for type 2 diabetes by the end. Moving forward to some practical advice on the usage of SGLT2 inhibitors and how we are going to use the SGLT2 inhibitors. As a safety profile for the SGLT2 inhibitor, most genital infection happening with SGLT2 inhibitors are mild to moderate. So you have to advise the patient during starting the SGLT2 inhibitor to drink plenty of water and other liquids, and urinate often and wipe themselves comfy. And actually, this side effect in the Arab region is not an issue because due to the hygiene and the hygiene in the Arab region and Muslim countries, we are not facing this type of safety issue with the SGLT2 inhibitor. And there is a risk for increasing hypoglycemia when used in combination with sulfonylurea or insulin. So our advice is to decrease the dose of sulfonylurea or insulin, of course, for type 2 diabetic patient when combining with EMPA or SGLT2 inhibitors. Diabetic ketoacidosis is very rare and they can be mitigated. There is no risk with EMPA with either lower limb amputation or foreign gangrenes. They are not increased during our safety trials. As a conclusion, the recommended dose for empagliflozin is 10 milligram. SGLT2 inhibitors and EMPA are not recommended for patient with type 1 diabetic mellitus, not indicated for pregnant women, not indicated for nursing patients, patients less than 18 years, or those with low eGFR. And remember, the tablet can be taken with or without food, swallowed with water. Preferably, the dose should be taken before the first meal of the day. If the dose is missed, it should be taken as soon as the patient remember. Pay attention to the hygiene to minimize the genital infection, and check extremes for problem with circulation and water. And this is a general precautions for diabetes mellitus patient at generally. Finally, this is our dose with eGFR with patients. Start EMPA when the eGFR is more than 60 millimeter per minute. No dose adjustment below 60. Discontinue when the patient's eGFR is lower than 45 millimeter per minute. and don't initiate if the eGFR of the patient is lower than 60 millimeter per minute. And this is as per our Saudi label and label here in Saudi Arabia. Thank you for your time. Hoping to answer any question if needed.
Thank you, Dr. Muhammad.
Thank you.
For this nice lecture. I want to thank you, and if you're interested, you can join us in the discussion time. Now time of break.
Thank you.
Thank you. We'll take a break for I think 20 minutes. We'll be back at 8:50 إن شاء الله 8:50 PM بإذن الله عز وجل. نتوقف لأداء الصلاة ثم نرجع بإذن الله عز وجل 8 و5. Thank you.
Inshallah. Thank you, Doctor.
بارك الله. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه أجمعين. Welcome everybody for coming back from the break. I want to thank you all for attending this meeting. I hope it's very beneficial for you. Inshallah, Ramadan Mubarak for all of us. And نسأل الله عز وجل نبارك لنا في شعبان ويبلغنا رمضان جميعا ونحن في صحة وعافية. The first speaker in the last session today is Dr. Manhal Ridwan. Dr. Manhal Ridwan, she is a consultant endocrinologist and also internist at Noor Diabetes and Endocrine Center. Dr. Manhal will talk about the important issue about Ramadan fasting, management of diabetes during Ramadan, who is taking oral hypoglycemic. Dr. Manhal, you can.
My talk today is about management of diabetes during Ramadan in people with the type 2 diabetes on oral hypoglycemic agent. Based on many guidelines, this figure shows the main dose adjustment and modification for many of the most commonly used oral anti-diabetic agents based on the diabetes and Ramadan guidelines. While the metformin is the most common and widely used anti-diabetic oral drugs, there is no randomized controlled trial have been conducted on metformin therapy in people with a type 2 diabetes during Ramadan. While based on the guidelines, the changes to the metformin dosing during Ramadan, it is not much. In people taking a once daily dosing, there is no dose modification is usually required and to be taken at the iftar. At the same time, also the twice daily dosing medication or metformin, there is no need for the dose modification is usually required to be taken under the iftar and at the sahur time. While people with the 3 times daily dosing, the morning dose to be taken before sahur, while the combined afternoon dose with the dose taken at the iftar. Who is taking the prolonged release metformin, there is no dose modification usually it is required and to be taken at the iftar time. The same for the acarbose. There is an randomized control trial have been conducted on acarbose as a monotherapy in people fasting during Ramadan. However, the risk of the hypoglycemia is low for this type of medication. The only thiazolidinones, TZDs, used as oral anti-diabetic agents is the bioglitazone, and there is limited data, although there is some studies to assisting its use during Ramadan. One of these is the double-blind randomized control trial. It was conducted in India. With comparing medication is the oral hypoglycemic drugs comparing to the placebo. The number of the hypoglycemic events, it was higher in the bioglitazone group, which was not a significant result. And the bioglitazone group have less fructose levels early Ramadan, in the mid-Ramadan, and also in the post-Ramadan period, with increasing in the body weight in the bioglitazone group in comparing to the placebo. For the short-acting insulin secretagogues, such as the ribaglinide, in 2 small observational studies, there is no hypoglycemic event were reported in the patient treated with the ribaglinide during Ramadan. While the 3rd observational study shows no difference in the hypoglycemia when it compared with the insulin glargine or the glimepiride as a sulfonylurea class. In another two randomized parallel group trials, there is a low incidence of the hypoglycemic event was associated with the ribaglinide treatment during Ramadan, which occur in a similar proportion of patients treated with the glibenclamide and the glimepiride. That's why the recommendation is that the daily dose based on the 3-meal dosing, it may be reduced or distributed to 2 doses during Ramadan according to the meal size. Phenylurea, also it is one of the most common oral antidiabetic drugs that is used as a part as a management of people with the diabetes type 2. It acts by stimulating the insulin secretion from pancreatic beta cells in a glucose-independent process. Because of this, it has increased risk of the hypoglycemia during fasting in Ramadan. In many studies, as regard the using of the sulfonylurea during fasting of Ramadan, the proportion of the patients experiencing the hypoglycemic events was higher in the glibenclamide group as compared to the other newer generation of the sulfonylurea, such as the gliclazide. In another randomized trial, which is assessing the incidence of the hypoglycemia in Muslim patients with the type 2 diabetes treated with sitagliptin or sulfonylurea during Ramadan, it shows less hypoglycemic event in the sitagliptin group with a 6.6% in comparison to the sulfonylurea, but which is much higher in the glibenclamide group by 19.7%. One of the recent multinational observational study done, which is a real-world study done in people with a type 2 diabetes treated with a gliclazide modified release during a fasting, which is a Daya Ramadan, which assessing the efficacy and the risk of hypoglycemia in gliclazide modified release drug, either alone or in it's as add-on therapy to the other oral antidiabetic agents. It shows that the patients with confirmed of hypoglycemic events of 1 or more, it is much less. It is only a 1.6%, which indicates that the safety use of this medication during Ramadan. So by the recommendation, the changes to the sulfonylurea dosing during Ramadan, who is taking the once daily dosing taken at the iftar, but to be considered that the patient with a well-controlled blood glucose level, the dose may be reduced, while the who's on a twice day dosing, the iftar dose remains the same. In patients with a well-controlled blood glucose level, again, the suhoor dose should be reduced. While people on the older drug in this class, such as the glibenclamide, better to be shifted to a second generation sulfonylurea, such as the gliclazide or the glimepiride, in a preference to the older class. What about the DDP4 inhibitors? And one, it is safe and efficacious to be used during Ramadan. In a study assessing the vildagliptin therapy and the risk of hypoglycemia in people with the type 2 diabetes during Ramadan, it shows that the group on the vildagliptin group had better A1C level in pre and post Ramadan period, and again there is an increase in the body weight in the sulfonylurea group comparing to the vildagliptin. Here they are examining between comparing the vildagliptin and the gliclazide as a medication or as a sulfonylurea class. In another study, which is a virtue study, which assessing the hypoglycemic event during Ramadan, comparing between the vildagliptin versus the sulfonylurea. The data is collected from 1,315 of fasting type 2 diabetes from 10 countries. The patient who is experiencing of one symptomatic hypoglycemic events is much in the sulfonylurea group comparing to the vildagliptin with a 19.8%. while there is no much evidence as who is to experience a severe episodes of hypoglycemia in both groups. Again, another randomized trial that assessing the incidence of the hypoglycemia in people with the type 2 diabetes treated with the sitagliptin or sulfonylurea during Ramadan. The sitagliptin group was less comparing to the sulfonylurea, especially the older generation. In a systematic review and network meta-analysis of randomized controlled trial and observational study, it shows that when all the relevant study were taken into account, it shows that the DDP4 inhibitor associated with the lowest incidence and rate of hypoglycemia even comparing with the sulfonylurea. So the recommendation is there is no dose adjustment is needed during Ramadan as the risk of the hypoglycemia is low with this group. What about the glucagon-like peptide 1 receptor agonist? In a randomized controlled trial comparing the GLP-1 receptor agonist, liraglutide, to the sulfonylurea as add-on to metformin in a people with the established type 2 diabetes during Ramadan, which is called the Treat for Ramadan trial, the number of the population was 99. The self-recorded hypoglycemic episodes of less than 3.9 millimole per liter were less in the liraglutide group in comparing to the sulfonylurea, where there was no severe episode. And the change in the A1C level in 3 weeks post-Ramadan was much higher in the liraglutide group comparing to the sulfonylurea. And again, in the 12 weeks post-Ramadan period, the liraglutide group has higher or better control in the A1C level in comparing to the sulfonylurea. And again, as its effect on the body weight, the 3 weeks post-Ramadan period, the liraglutide had lower or more reduction in the body sulfonylurea, and again in the 12 weeks post-Ramadan period has the same result. In another study which assessing the efficacy and the safety of the liraglutide comparing to the sulfonylurea during Ramadan in patients with the type 2 diabetes, which is Lira Ramadan, which is a randomized trial. The number of the population was 343. The symptomatic hypoglycemic events during Ramadan were much less in the liraglutide group comparing to the sulfonylurea group, and the symptomatic events from the baseline to the end of Ramadan, again, it is less in the liraglutide group. While as regard the glycemic control, the fructosamine level was less during Ramadan. It was the same in the same group, but the fructosamine reduction from the baseline to the end of the Ramadan was much better in the liraglutide group in comparing to the sulfonylurea. While the A1C level reduction from the baseline to the end of Ramadan, it was higher in the liraglutide group in comparison to the sulfonylurea. And again, the body weight during Ramadan it was reduced in the liraglutide group in comparing to the sulfonylurea. And again, if it is compared from the baseline to the end of the Ramadan, in the liraglutide group, it was higher. In another recent international randomized open-label trial, which is the Lixaram, which is assessing the safety of the lixinetide versus the sulfonylurea to the basal insulin treatment in a people with a type 2 diabetes who elect to fast Ramadan. It is a phase 4 randomized open-label trial. Takes 12 to 22-week study in people with type 2 diabetes who are insufficiently controlled on the oral anti-diabetic agent. So those that took the lixinetide had a fewer documented hypoglycemic events than those on the sulfonylurea, with a 3.3% and 8.9% in the sulfonylurea group. And the difference was statistically significant for any hypoglycemia in the it was less in the lixinetide and basal insulin group compared to the sulfonylurea and the basal insulin group. In the South Asian consensus guidelines, as regard the use of the GLP-1 receptor agonist during Ramadan, the recommendation was to the better time to start the short-acting, intermediate-acting, or the once-weekly long-acting GLP-1 agonist must be done at least 6 to a 3-month period to start of the Ramadan. And this time period is required. Why? To ensure and achieve a steady state of concentration and a better period to assist the glycemic control and to address the potential gastrointestinal symptoms before the start of the Ramadan. So, but as per recommendation, as long as the GLP-1 agonists have been appropriately dose titrated prior to Ramadan, there is no further treatment modification is required. One of the new also oral antidiabetic agents that have efficacy to reduce the cardiovascular event is the sodium glucose cotransporter 2 inhibitors. It has demonstrated effective improvement in the glycemic control and the weight loss and associated with a lower risk of the hypoglycemia. Usually, the risk of Ramadan fasting in diabetes in people with diabetes type 2 using the SGLT2 inhibitor is the hypoglycemia, the hyperglycemia, and the dehydration, the DKA, thrombosis, and the risk of pregnancy. While the new or the studies that are available assessing different type of the SGLT2 inhibitors, one of them assessing this the study drug was the dapagliflozin in an open label randomized 2-arm parallel group study done in Malaysia. The additional medication in this study was the metformin in comparison to the sulfonylurea. The events of the hypoglycemia was less in the dapagliflozin group in comparison to the sulfonylurea, with a 6.9% versus the 28.8% in the sulfonylurea group, with no significant difference in the A1C level or the fasting blood glucose or the fructose level was observed between the two groups, but there was associated side effect of a postural hypotension, which is much in the dapagliflozin group in comparison to the sulfonylurea, with a 13.8% versus 5.8%. While the UTI infection, it is much in the dapagliflozin group comparing to the sulfonylurea. In another study assessing the dapagliflozin and the canagliflozin done in the Emirat, the number of the population was 95, and the study type it was a prospective controlled study. The additional medication was used is the sulfonylurea and other hypoglycemic agent, not including the sulfonylurea and insulin, in comparison to the individuals who is not taking the SGLT2 inhibitors. The hypoglycemic events measured through the flash glucose monitoring system, it was 3.9% of those on the SGLT2 inhibitor, comparing to 3.3% of those who's not taking the SGLT2 inhibitor. And this difference, it was not significant. While there is no reported cases of any adverse events and no statistically significant changes to the systolic blood pressure reporting in either group. But we have to take into our account also that it has to be to be used in a selective use in a specific population, such as the people, the elderly, or the who are hypotensive individuals or on diuretic therapy. But as per recommendation, based on those studies, during Ramadan, there is no dose adjustment is required and to be taken at the iftar time. What about the people or individuals on multiple anti-diabetic therapy? In a pro-fast Ramadan study, assessing the incidence of the hypoglycemia in patients with the type 2 diabetes taking multiple glucose-lowering therapy during Ramadan, they implementing the DAR IDF guidelines with the pre-Ramadan education and the adjustment of the oral and the injectable glucose-lowering therapy based on those guidelines. They found that the overall incidence of the hypoglycemia, either the symptomatic and the confirmed with the blood glucose reading during Ramadan, was 16.3%, with the highest incidence in the group with insulin, sulfonylurea, and other agents, about 31%. The risk of hypoglycemia was greatest among individuals on a combination of basal insulin, DDB4s, and metformin, and those on 4 or more of the glucose-lowering therapy. With the same, the fast intelligence technology study, which is by using this machine, they can assess the glucose variability and the episodes of the hypoglycemia before and during Ramadan. And actually, the hypoglycemic episodes was decreased, or the mitigation of the hypoglycemia was achieved by reducing the dose of the basal insulin or the sulfonylurea according to the Pro-Fast Ramadan protocol in the previous study. In another study, which is an observational study, which assessing the tolerability of the canagliflozin in patients with a type 2 diabetes fasting during Ramadan, it shows that the proportion of the patients who experience of symptomatic hypoglycemia was much in the sulfonylurea group in comparison to the canagliflozin group. And again, the number of hypoglycemic events, it is much high in the sulfonylurea if it is compared to the canagliflozin group. So the risk of the hypoglycemia is determined by multiple factors, including the medication, the duration of their diabetes, the renal function, the pre-Ramadan glycemic control, and if there is associated other comorbidities. The most important is the post-Ramadan follow-up. Patient with the diabetes should be aware of the risk of the over-indulgence during this time, and in order to discuss the medication and the regimen adjustment and to assess how the patient handled the fasting to take into account on their next time of fasting. And thank you so much.
Thanks, Dr. Manhal, for your nice presentation. It was really informative and comprehensive. So maybe now for the last lecture today for our meeting. Last lecture today is supposed to be presented by Dr. Faisal Al-Malki, consultant endocrinologist and head of the Noor Diabetes Center. But due to unexpected circumstances, he is unable to present, and he is replaced by Dr. Mayada Samkari. Dr. Mayada, she is a board-certified doctor, family physician, and a diabetes fellowship fellow as well. Dr. Mayada will talk about insulin management during Ramadan. So, floor for you, Dr. Mayada.
Fellow F1 from Noor Specialist Hospital in Mecca City. So I'm going to talk about management of diabetes during Ramadan, the insulin therapy. The outlines are the management of type 1 diabetes when fasting during Ramadan and type 2 diabetes when fasting during Ramadan. So regarding management of type 1 diabetes, Ramadan fasting in people with type 1 diabetes, this is a DAR global survey, showed this study 13 Muslim populated countries, and the survey during post-Ramadan visit was in June, August 2020. This study focused on intention and abilities to fast and impact of COVID-19 and rates of hypoglycemia and participant response during Ramadan fasting and rates of hyperglycemia and participant response during Ramadan fasting and self-monitoring of blood glucose and type of education received. The total population was 1,483 type 1 diabetes participants. So the majority intended to fast, about 71%. So 60% of this 71% was from case A, and then 15.1% from Egypt, then 7.1% from United Arab Emirates, and then after that, Pakistan and Malaysia and UK and Algeria and Morocco and Turkey, and there is others also including in the study. So this graph or this chart shows the rate and frequency and timing of hypoglycemia during Ramadan fasting. If you see here regarding the age, the people less than 18s in comparing to people more than or equal to 18 years, the people more than or equal to 18 years have more rate of hypoglycemia in comparing to less than 18 years. And regarding the frequency, about 1 to 7 days per month of Ramadan having hypoglycemic attacks. And regarding the timing of the hypoglycemia, the majority of them between 3 p.m. and Maghrib time. So the current recommendations for insulin dose modifications during fasting Ramadan in type 1 diabetes, it depends on the risk stratification. So no longer automatically assessed as increased. The risk weighted according to duration of diabetes, hypoglycemic risk, and glycemic control, and complications and other factors. So it depends on the type, as we see here. If type 1, we will give 1 score. If the duration of diabetes is more than 10 years, we will give 1 more score. So this is the scoring. If more than 6, it will consider as high risk. Actually, this is a DAR application released by IDF DAR in the previous couple of weeks. It's called DAR Academy. It's online, and we can download it on Android and Apple also from Apple Store. It showed that we can download it. Then it shows all the risk factors, but just by clicking on the each category of the questions, and it will show the risk. And we will give you an example at the end of the presentation. So pre-Ramadan assessment and risk stratification, it is important all individuals with type 1 diabetes have pre-Ramadan assessment well before the beginning of Ramadan, actually between 4 weeks to 6 weeks like this. So risk stratification and Ramadan focus education. And it is the risk stratification should be highly individualized and account for the following: the pre-Ramadan glucose control, duration of type 1 diabetes, for example, that those newly diagnosed may be within the honeymoon period, and hypoglycemic risk, level of hypoglycemia awareness, level of diabetes-related education, motivation for SMBG, ability to take appropriate decision-making, the visibility of and access to continuous glucose monitoring and advanced insulin delivery technology, the presence of diabetes-related complications or associated autoimmune disorder like celiac disease or thyroid disorders. So the patient with type 1 diabetes usually considers high risk, but a patient who have any of the following considered strongly, should be advised strongly not to fast, who have history of recurrent hypoglycemia, hypoglycemia unawareness, poor diabetes control, brittle diabetes, non-compliance with medical treatment, unwilling or unable to monitor and manage blood glucose levels. So those who insist on fasting must be made aware of all the potential risks and will require close medical supervision. So regarding the management of type 1 diabetes, basal bolus versus conventional therapy, the basal bolus regimen is preferred over the conventional twice daily regimens in adolescents with type 1 diabetes. Basal insulin should be adjusted according to the fasting blood glucose levels to reduce hypoglycemia during fasting. Bolus insulin before iftar and sahur using ICR and ISF-based corrections are recommended in order to control postprandial and evening hyperglycemia. The premixed insulin regimens are incompatible with safe fasting and should be discouraged. So this study done in Saudi Arabia, the study name was insulin glargine time of injection during fasting in Ramadan in patients with type 1 diabetes. So this chart shows to the left side if glargine taken at 7 p.m. and the right side it shows the group taking glargine at 12 midnight. So if we see here, the both groups have equal or a near range of hypoglycemia, as it shows in green color. Here it's 13% and here it's 12.16, and also above the target, about the same percentage in both groups. So in patients with type 1 diabetes who fast during Ramadan, there does not seem to be an advantage of changing basal insulin glargine time into earlier evening hours in regard to difference in rates of hypoglycemia. To the best of our knowledge, this is the only study directly comparing two different timings of giving insulin glargine during fasting Ramadan in type 1 diabetes, and larger studies are needed. So the insulin modification, if a patient is in basal insulin, we will look at the A1C. If it is less than 7.5, we will reduce the dose by 20 to 30%. If it is more than 7.5, so we will keep the same dose. If the dose taken daily, so it can be taken at iftar or late evening or pre-Ramadan time. But if taken BID, we can the patient can take the AM dose at iftar and reduce the PM dose by 50% and taken at sahur. Regarding the bolus insulin, if the patient on fixed doses, so take the normal dose at iftar and reduce sahur dose by 25 to 30% and omit the afternoon dose. If the patient on ICR and ISF, so keep same for iftar and sahur. For better control, for postprandial control, it is advised to take the bolus 20 minutes prior to iftar to account for the high fat or high protein meals. High blood glucose may require extra correction based on ISF. Correction must not be more frequent than every 3 hours to avoid insulin stacking and hypoglycemia. Recommended monitoring: if the patient on insulin pump or continuous sub-Q insulin infusion, recommended to be on CGM. But if the patient on MDI or premixed insulin, so it's about like 5 to 7 point of SMBG during the day. So recommended dose adjustment according to SMBG. If the patient on once daily long-acting basal insulin, if he's taking during the fasting hours, it means in morning, midday, or before iftar, if the blood glucose between 90 and 160, so no dose adjustment required. But if between 160 and 250, so we will consider increasing the basal insulin by 10 to 15%. And if it is more than 250, we will consider increasing by 20 to 30. But if it is less than 90, we will decrease it by 15 to 20. But the patient, if he is on twice daily basal insulin, so no dose adjustments the same if it is between 90 and 160, but adjusting the dose, the late evening dose, actually, the dose taken at sahur. So regarding the non-fasting hours, it means post-iftar, midnight, and pre-dawn. If patient on once daily long-acting insulin, so dose adjustment depends on the short-acting insulin at iftar, sahur, and snack in between. Apply ICR calculation of meal contents for dose changes. Avoid high carb and fat contents in meal, as that will reflect on blood glucose levels through night and early morning. But the patient, if taking the basal insulin twice daily, so no dose adjustment be required if the blood glucose between 90 and 150. It's same like the previous one. If taken twice daily, adjusting iftar basal dose. But if the fasting hours measured during the fasting hour, adjusting the basal dose at sahur. If the patient on insulin pump, so the basal insulin rate will be reduced 20 to 25% in the last 4 to 5 hours before iftar, and increased by 10 to 30% after iftar up to midnight. And the bolus insulin or brandial insulin is calculated based on usual ICR and insulin sensitivity factor. So bolus doses on insulin can be delivered in 3 different patterns: immediately as a standard or normal bolus, slowly over a certain period of time, square bolus, a combination of 2 or combo dual wave bolus. Meals high in fat content may need an extended or combo bolus, as the rise in blood glucose following the meal will be delayed by fat content. It is recommended to use bolus calculators in determining carb and correction dosing to avoid insulin stacking and hypoglycemia. So in summary, for type 1 diabetes in Ramadan, type 1 can fast provided proper planning and individualized care for education and dose adjustments. Frequent glucose monitoring is essential. Insulin analogs are preferred over conventional regimens. Advanced insulin technology seems very promising in allowing safe fasting. Higher quality research is needed to enable proper risk stratification of type 1 diabetes patients and to guide fasting regimens and dose modifications. Now we will go to talk about management of type 2 diabetes when fasting during Ramadan. This is a case scenario. Saudi male, 62 years of age, retired. His weight is 89 and body mass index 30 and blood pressure is 130/74. Diagnosed with type 2 diabetes 6 years ago. Renal function is normal with GFR 98. He is on insulin glargine 20 international unit taken at 10 p.m. and insulin aspart taken 868 international unit pre-meals and on metformin 500 milligram TIDPO. He attends your clinic before Ramadan and his latest A1C is 10%. No history of hypoglycemia, SMBG conducted as indicated, and the fasting between 250 and 240, and the postprandial between 230, and at 3 a.m. it's 200. Patient on poor lifestyle, no micro or macrovascular complication, he's willing to fast and he asked for your advice. So we will depend on the risk stratification as in type 1. Risk no longer automatically assessed as increased. So we will depend on the type of therapy, of insulin therapy. If the patient on multiple daily mixed insulin, we will give 3 risk score. If a patient on basal bolus or insulin pump, will give 1.5 risk score. If the patient on once daily mixed insulin, we will give 2 risk score. If he is on basal insulin only, so we will give 1.5 risk score. Actually, this study in Darmina type 2 international perspective study showed that the patient type 2 diabetes who's taking insulin and other oral hypoglycemic agents showing more confirmed hypoglycemia during Ramadan in comparing 4 weeks before Ramadan. And actually all the other groups also having high frequency of confirmed hypoglycemia during Ramadan in comparing 4 weeks before Ramadan. So the hypoduration, depending on the basal, about 47. So an intensive therapy, 86.3. The number of hypos less than 50. So it's about 0.4, and on intensive therapy, 1.5 plus minus 2.6. So can we adjust insulin therapy? It individualized. It is individualized treatment, so we can continue the current therapy or adjusting the dosing for current therapy or adjusting the timing of doses or changing to different drug or change to different combination of drugs or change to different form of the current therapy or a combination of the above. This is a practical consideration. Many individuals on insulin therapy elect to fast irrespective of their risk level and the advice of their physicians. While the primary focus on the risk of hypoglycemia, care should also be given to glycemic control during Ramadan. The insulin level must be individualized by taking into account education, preferences, diet, and lifestyle. So some authors recommended switching twice daily premixed or intermediate acting insulin to long acting insulin or intermediate acting insulin in the evening and rapid acting insulin with meals. Changing the regimen only for Ramadan period may lead to errors, non-adherence, and require additional education that is not really available due to time and resource constraints. The individual's pre-Ramadan glycemic control will determine whether insulin dose reductions are required or not. So regarding the medical management, the basal insulin therapy, observational trials have demonstrated safety with the basal insulin when used in combination with the oral agents. If we see here, this study comparing the glimepiride, ripaglinide, and insulin glargine about the same percentage of hypoglycemia occur, 14%, 11%, 10% respectively. So most have used analog insulin, and all the data show safety for using basal insulin during Ramadan, and administration of insulin via sub-Q, IM, or IV routes. We should insist the patient that it will not causing breaking of the Ramadan fast. This is also an updated trial, Orion trial, about insulin Toujeo or glargine 300. Majority of participants fasting for the full month of Ramadan, having low incidence of symptomatic hypoglycemia and no episodes of severe hypoglycemia, and demonstrated that glycemic control can be successfully intensified in Ramadan. So this is also a study showed basal insulin comparing with GLP-1 receptor agonist during Ramadan. So the liraglutide plus insulin with sulfonylurea, the hypoglycemia was about 16.2%. And lixisenatide plus insulin or insulin plus sulfonylurea having lower rates of hypoglycemia in group having on insulin and lixisenatide. This is in detail. If you see here, the patients on lixisenatide and basal insulin having the hypoglycemia about 4.3%, comparing to persons on sulfonylurea and basal insulin about 17.4%. So now we will talk about the prandial insulin, analogs versus human insulin. So the analog may reduce the risk of hypoglycemia, and prandial insulin analog could be associated with a lower risk of postprandial hyperglycemia when compared to human insulin. Insulin analogs are injected just before meal, so can be administered at the time of iftar or sahur instead of 30 minutes prior to the meals. Regarding the premixed insulin, it is the commonest insulin regimen used in many countries, usually take a low ratio, 25 to 75 or 30 to 70, between short and rapid acting and intermediate acting insulin. The challenges with using low ratio premix that it may provide inadequate prandial cover in the evening for the resultant postprandial hyperglycemia. And the doses of prandial insulin cannot be inadequately adjusted, leads to risk of both postprandial hyperglycemia and hypoglycemia after sahur. So our options, we can using a higher ratio of premixed insulin at iftar. For example, the patient can use 50 premixed insulin at iftar and 30 premixed insulin at sahur. Or the patient can be changing to alternative regimen like basal plus prandial or basal plus GLP-1 receptor agonist. This is also an updated trial about insulin degludec with aspart. The insulin degludec 70% and the 30% of insulin aspart. It can be used safely in Ramadan, statistically having lower incidence of overall hyperglycemia, about 74% reduction, and demonstrated similar glycemic control. So now the dose adjustment. Recommendations. When premixed insulin are used, the following guide should be considered. If the patient on once daily dosing, it can be taken normal dose at iftar. If the patient on twice daily dosing, so take the normal dose at iftar, but reduce the sahur dose by 20 to 50%. If 3 times daily dosing is taken, so we will omit the afternoon dose and adjust iftar and sahur doses. The titration will be every 3 days. So where very high doses are used, change of 10 to 20% of the dose may be a more meaningful dose changes. If the patient is taking long or short acting insulin, so the long or intermediate acting insulin, if taken once daily, we can reduce the dose by 15 to 30% to be taken at iftar. If taken twice daily, take the usual morning dose at iftar and reduce evening dose by 50% to be taken at sahur. If the patient on short acting also, so normal dose at iftar, but omit the lunch dose and reduce sahur dose by 25 to 50%. If the patient on insulin pump therapy, so education and appropriate patient selection is essential. A low reduction of risk of hypoglycemia and hyperglycemia, and can lower or suspend the basal insulin infusion rate during fasting. Meta-analysis of type 1 diabetes showed that the continuous sub-Q insulin infusion regimen had low rate of hypoglycemia or ketosis, but a higher rate of non-severe hyperglycemia than that of MDI. Sensor augmented pumps and closed loop automated insulin delivery may reduce risk further. So changing, as in type 1 diabetes, we will reduce the dose by 20 to 40% in the last 3 to 4 hours and increase the basal rate by 0 to 20% early after iftar. And regarding the bolus, it depends on the ISF and ICR. So the continuous glucose monitoring with education could result in better glycemic control than the self-monitoring blood glucose. And the flash CGM system provide a more affordable option, which have been developed to predict hyperglycemia and hypoglycemia excursions that may make safer fasting possible in higher risk individuals. And it must be emphasized to patients that finger prick testing does not invalidate the fasting. So we can advise the patient for a trial fast, fasting for 3 consecutive days before Ramadan, for example, al-Ayyam al-Bid 13, 14, and 15, and can detect, during this period, the patient can detect the hypoglycemia risk and may guide self-titration of insulin dosage and may help to identify fasting or postprandial hyperglycemia. So in summary, for type 2 diabetes, insulin can be safely used in appropriately selected patients. Now we have evidence for use of insulin degludec with aspart and insulin toujeo with the lower risk of hypoglycemia. Insulin therapy must be individualized for patients considering baseline control, education, preference, and diet during Ramadan. Self-titration monitoring are essential if insulin is to be used safely. So we will go back to the case scenario. He is a Saudi male, 62 years of age, retired, and his weight 89, body mass index 30, blood pressure 130/74, diagnosed type 2 diabetes 6 years ago, renal function is normal with normal GFR, the insulin glargine Lantus 20 international unit, and aspart 868 pre-meals, and also on metformin TID, attends your clinic before Ramadan, and his latest A1C 10, no history of hypoglycemia, SMBG conducted as indicated. The fasting is 250 to 240, and the postprandial 200 to 30 with 3 a.m. SMBG 200. He's on poor lifestyle, no macrovascular complication. He's willing to fast and ask for your advice. So we can use DAR Academy application and calculating the risk. If we see here, we can put all the categories, and also the A1C, it is more than 10, and he's on basal bolus. The SMBG conducted as indicated, no complications, no microvascular complication, GFR more than 60, and not pregnant, no frailty, no physical labor, no negative or positive experience, and the fasting is more than 16. So it's quick application. We can classify the patient on easily like this. He's in moderate risk. So if we see here, regarding moderate risk, so we can advise the patient regarding medical recommendation and medical evaluation, medical adjustment, strict monitoring, and he can fast. But regarding the religious recommendation, fasting is preferred, but the patient may choose not to fast if concerned about his health after consulting the doctor and taking into account the full medical circumstances and patient on previous experience. If patient fast, they must follow medical recommendation and including regular blood glucose monitoring. So our impression about this case, it is uncontrolled DM, Ramadan fasting risk score is moderate, and he's obese. The plan, as fasting blood glucose not controlled, increase the insulin Lantus 2 unit Q3 days till controlled, and the postprandial also not controlled, so we can increase the pre-meal aspart as every 3 days with insulin titration education modification, and continue metformin. And insulin titration hypoglycemia education should be given, and also refer to dietitian and education. We consider GLP-1 receptor agonist as he is obese, like for example, once weekly dulaglutide, but not now because it's almost 2 weeks before Ramadan, and it's better to be about 1 month or 1 month to 3 months before Ramadan because of the side effects. So regarding the plan for dose adjustment during Ramadan, as his A1C not controlled, so continues the same dose of Lantus and to be taken at iftar or decrease it by 15 to 30 as the guideline said. Regarding the pre-meal aspart, omit the afternoon dose and give morning dose pre-iftar and evening dose pre-sahur with dose adjustment according to SMBG. And the patient can continue on metformin with 2 tabs, 500 milligram after iftar, and remaining 500 tab after sahur. The SMBG to be taken regularly at least before sunset, 1 to 2 hours after meal, once after fasting, anytime feeling unwell. And also we will consider the breaking the fast rule and refer the patient to dietitian. And we can advise the patient to use Dar Safa application for helping in diet and exercise during Ramadan, and to know more general advices about fasting of diabetic patient during Ramadan, and follow up post Ramadan to readjust medications. So this is Dar Safa application. The patient can be downloaded on Android or Apple iPhone, I mean. So it shows here like the patient can be using quickly, as he can make any of the choices and make his own Ramadan nutrition plan. It will show the breaking fast rules, the type of exercises, and including Taraweeh, it is a type of exercise. And everything it's mentioned here, and also the amount of fluid. It is nice application, and the patient can easily use it. And also the patient can make his own plan, but every day by day, so it is an easy application. You can see it at your phone, iPhone or Android. This is the barcode of Dar Academy, which is used for the healthcare providers on Apple or Android, and Dar Safa for the patients on Apple. This is the barcode, and this is on Android. And thank you.
Thank you, Dr. Mayada, for this very comprehensive and interesting lecture. I want to ask all our speakers to be live, and if you don't mind, you open the camera and also the phone, please, the microphone. Okay. حياكم الله جميعا, our audience and our eminent speaker. I want to start with the first question, and how many, I think for Dr. Nida Bukhari, how many type 2 diabetic patients can complete 15 days fasting Ramadan?
Assalamu alaikum.
Salam.
Yes, Dr. Humaid, can I share the content?
Yes, I will give you the Dr. Nida. Yeah, you can. If you have any idea, you can talk only if you have.
Yeah, of course. Regarding to the question, I have this slide from my my lecture. This slide was talking about the type 2 diabetes who fasted in Ramadan. Actually, about 94% of the patients with type 2 diabetes has fasted more than 15 days during Ramadan. And as we can see here, more than 32% of the patients fasted less than every day, but 64 or 67.6% of the patients fasted every day in Ramadan. So the answer for this question is about 67.6 patients of type 2 diabetes has completed the whole month of Ramadan.
Okay, I think it depends on the medication. Also, if the patient taking insulin or sulfonylurea, is risky for hypoglycemia and break fasting. That's why I think the risk stratification and also modification of the dose before Ramadan, and also instruction for our patients, it's prevent them to break their fasting. Dr. Bender? الصوت أظن حق
Yes. Let me share with you, Dr. Hamid, some of the questions here. I think this one for Dr. Ashan, maybe for risk stratification or classification. We have a patient with type 1 patient. He fasted Ramadan. He is controlled on MDI. He has no hypoglycemia, no history of DKA for the last 6 months. I think the question here, what is your advice? He should go for fasting or no according to the categories. What do you think?
Assalamu alaikum. Think about type 1 previously considered as high risk for fasting. And what the advice was always advise them not to fast because of high risk of complication. But with the new scoring system, they considered as a moderate risk, especially the data or information available in the question. I think type 1 per se will take 1. Of course, type 1, he will be on multi-dose insulin, so he'll take 3. So at least he will take 4 with available information. I don't know about the duration. I don't know about is he cooperative doing SMBG, the control of his blood sugar, presence of macro or microvascular complication, his experience from previous Ramadan. But anyhow, with available information, at least he's moderate risk. So moderate risk, the fasting from a medical point of view is uncertain, the complication. But if the patient preferred fasting, yes, type 1, he can fast, especially if you have the data from Darmina, around 48 of type 1 able to fast Ramadan fully, with a good education, with a good adjustment of medication, presence of a new CGM last for 7 days and flash glucose monitoring, which is predict the hypoglycemia before the patient can fast Ramadan safely. I think.
Okay. Yes, it's clear, Doctora. Yes, maybe we have to know, I mean, the complete scenario, but as you mentioned, this is from information provided. This is the advice that we can go further. Okay, we'll go further, Dr. Hamid, if you allow me to help you. We have a question here for Dr. Salwa, I think. At which blood sugar patient can go for breaking the fasting? Dr. Salwa, I think you shared with us some data. Can you elaborate more when to break the fast? دكتورة سلوى ما نسمعك.
ممكن شغلين المايك.
دكتورة سلوى تسمعين؟
أيوه.
Yes.
Sorry for this issue. I had a technology issue. Actually, I shared a slide that patient with diabetic should break their fasting at level of blood sugar less than 70 or more than 300. And if they have a symptom of hypoglycemia or they develop acute illness or they have a severe dehydration, at that time they have to break their fast.
Okay. There is one question about from Dr. Sarah. Does for Dr. Manhal also, does the patient on SGLT2 inhibitor at risk for diabetes ketoacidosis? And is there any need to stop this medication before Ramadan or during fasting?
For the SGLT2 inhibitors during Ramadan, there is actually no contraindication, and there is no further dose adjustment based on many factors. It is safe to be taken at iftar time with good fluid intake during the iftar period, as the risk of stratification is safe for the patient to fast during Ramadan. Before in 2016, yes, based on the previous guidelines for the DAR, yes, there is a consideration for the development of the DKA, but the rate is less. With the new recommendation, it is safe to be used without those adjustments.
Okay.
Depending on the risk factors, yes.
Yes, as we mentioned, as you mentioned, Victoria, yes, SGLT2 maybe it is not, I mean, contraindicated, but maybe preferred to take in maybe at iftar because hydration is more after iftar, and to prevent any further, I mean, fluid loss. So it is recommended to be taken at iftar. طيب, we have here one question. I will comment on it. Is a pregnant lady on metformin can fast? Again, as Dr. Asjan mentioned, it depends, I mean, on the score. For example, if the patient, this pregnant lady is willing to go for self-monitoring blood glucose, if she is not willing to go for self-monitoring blood glucose, if it is controlled or not controlled, any history of DKA or hyperosmolar or diabetes emergency. So it depends on the score. Maybe if she has pure, I mean, no other issues, like she is only pregnant on metformin with no other issues, I think we can allow her to fast or give her the permission, but we have to understand all circumstances before going further.
Okay. There is one question for Dr. Mayada and anyone to share after Dr. Mayada. There is one 50 years old male patient on premixed insulin twice daily. He's taking 30 units morning and 20 minutes at evening dose. And his last hemoglobin A1C was 8. What your dose adjustment during Ramadan you would advise, and any recommended changes in his change his premix to MDI?
Okay, it's a nice question, and thank you. First, we will assess the patient risk score, and we will see in which class the patient. Then the next thing, the guidelines in IDF-DAR, it depends, as Dr. Nida said, it depends on expert opinion rather than medical evidence. So some authors recommend switching premix to MDI preferred. But in experience, we don't usually prefer changing the insulin regimen before Ramadan, like 1 week or 2 weeks. So to be on the safe side, we can keep the patient on the same regimen. But the issue with the premixed insulin, usually the patient are taking low ratio premixed insulin, like 30 to 70 or 25 to 75. And this ratio will not give adequate cover for the prandial glucose. So we can advise the patient to change premixed insulin. I don't see this صراحة in the practice, but we can change the premixed insulin at iftar time from low ratio to high ratio 50-50. And keep sahur time at the same. But if the patient continue on the same premixed insulin, the first twice daily, the first dose taken as the dose before Ramadan, and the second dose will be decreased 20 to 50% at sahur time.
Okay. I think there is also one question for Dr. Ashjan. Patient type 2 diabetic patient on 60 milligram glycoside MR. His hemoglobin A1C is 7.5. What dose adjustment you will advise? If you are around, Dr. Ashjan, or anyone volunteer to answer this one? I think I will answer because Dr. Bender he also answered one question. I think this patient is risky for hypoglycemia, especially his hemoglobin A1C is in middle target. So I think, as Dr. Mayada said, and also you mentioned preparing for fasting Ramadan with fast 2 days, 1 day before Ramadan, it tests your fasting time. I think it's safe to test the fasting before Ramadan. If it's okay, he can fast safely during Ramadan. But I think decreasing the dose a little bit of the glycoside, especially this patient is 60 years and his hemoglobin A1C in middle target, maybe it's better. The safety is better for this age.
I think we have one more question in the chat box. Insulin pump therapy, how is the adjustment in I mean in the basal bolus regimen of insulin therapy? I don't know who would like to comment.
Yes, Doctor. Yeah. Regarding the basal rate, تقريبا في آخر 3 ل 4 ساعات من الصيام يقلل البيزل ريت بنسبة 20 ل 30%، أو حتى 40%، وبعد الإفطار يبدأ يزود الريت، تقريبا ممكن برضو 20% من 0 to 20%.
We have one, if you remember, Dr. Hamid, one experience with a pregnant lady during Ramadan, maybe 3 years back. And mashallah, she continued her pregnancy and delivered the baby. So I think, yes, one of the options to control type 1, especially pregnant, especially in Ramadan, fasting, is the insulin pump. Anyone has another experience with pregnant ladies during Ramadan? Dr. Salwa, Dr. Nida, Dr. Manhal?
Also, I want to add with our patient, interesting. She's, mashallah, she had 3 pregnancy. I follow her during the last 3 pregnancy. One pregnancy, she was admitted in, I think, 1432 in Hira Hospital before, in MDI, frequent hypoglycemia during pregnancy. And also she passed يعني smoothly when she shifted to insulin pump, and also during Ramadan. I think insulin pump is also very beneficial for these type of patients, and also decreasing the basal rate during sleep and during the hours which is fasting is better. This patient, type 1 diabetic patient, as Dr. Ashjan said, and also we know this is a very high risk patient for fasting, and also being an MDI, also it's a lot of points is against fasting. So this patient is prohibited for fasting. Pregnancy per se is prohibited for fasting. Also added to insulin and insulin pump is very difficult for them. I think it's very better if insulin pump accompanied with the sensor. If the patient taking the sensor, freestyle libre sensor, or the sensor combined with the synchronized with the pump with auto stop method, is very helpful for these type of patients. I think in this point I want to thank all of our speaker, and رمضان كريم for all. إن شاء الله ربنا يتقبل منا ويبلغنا وإياكم ومن تحبون Ramadan. I want to announce one thing, the all recording of this lecture and this course is available live, available in our YouTube, and the link it's already in the chat box. You can copy and you can use it at any time, and it will be available till the end of Ramadan, inshallah. Thank you a lot. كل عام وانتم بخير، وصلى الله وسلم وبارك على